students, today we are going to speak about an interesting topic which I think some time back was not in the important chapters of pediatric books. As we came towards the 21st century, what has happened is less and less infectious disease are going to be there, and these developmental disorders, as we are going to have more and more nuclear families, we are going to get more of this developmental disorders in children. We are able to pick them up at an early age compared to about 2 to 3 decades back. Teachers in the schools are going to pick it up early. These children are taken to the developmental pediatricians and treated well. But it's very important for us. You as a general pediatrician, whether it's you are a specialist, if you see a child who has got this developmental problems, it's very important for us to pick it up early and get them into rehabilitative phase early as much as possible. One of the classical example is autism, because you can still pick it up by the age of about 2 years, then you're going to do wonders for his rehabilitation. And these developmental disorders, still many of it, we still don't know why it's there. But a lot of research is going on, a lot of new evidence is coming up. Hopefully within maybe a decade or so, we'll able to decipher what's the problem and have a treatment for these diseases. Of course, when a child is born to the parents, they visualize this child to be absolutely a normal child. And when at 2 years or 3 years, when they come with this developmental disorders and you give the diagnosis, for them, it's a catastrophe. So it's very important for us to find it early, then treat and try to produce or try to give a child which is of a national treasure. So it's very important for us to know about these disorders, all of it. Today's learning objectives, introduction into developmental pediatrics and developmental disorders, common developmental disorders with the case scenarios, and I would talk about what are the clinical features, how do you manage, and finally we have the quiz for you. I'm sure after going through this topic, you'll be able to answer that quiz without any problem. What is developmental disorders? These are neurological conditions that interfere with the acquisition, retention, or application of specific skills or set information in children. It involves dysfunction of attention, memory, perception, language, problem solving, and social interaction. For example, you give a problem, a normal child should be able to solve these problems. For example, you give cubes and ask him to put it one above the other, he should be able to do it. But if he can't do it at appropriate age, or social interaction, because when you see a child playing other children, you know it is normal. When there are 3-4 children are playing together, one child is away doing things on his own, you know there is some sort of a problem. Also the memory, also the attention. Child sitting not a single minute at one place, he'll be going about trying to do all sorts of things. That means there is inattention in him. And very important is that we should take a careful developmental history. I'm sure that you all need to work on this developmental history, taking the gross motor, fine motor, social and language. All these 4 important developmental histories should be taken to perfection. Regular developmental screening can pick up early. That means to say that when they come for high-risk clinics, or even for the immunization when they come, or a regular checkup, you make a habit of asking them a developmental milestones, and also all their files should contain a developmental chart which sort of gives you an idea what is wrong with the children. So what are the common developmental disorders what we see in a pediatric practice? One is global developmental delay, isolated delay. One particular function is delayed. You have attention deficit hyperactivity disorder, you have autism spectrum disorders, learning disabilities, intellectual disability, and stuttering. Let me go through all this as a case scenario. I think you will be able to understand each one of them in detail. Lovely child, Shriya, 2-year-old. She has not achieved sitting without support even at 2 years, because usually 8 to 1 year they would definitely attain this sitting. She tightens all 4 limbs while lifting. When you lift up, her limbs, lower limbs go straight. Difficulty in changing diaper by the mother. History of multiple episodes of seizures are there in this child. Birth history, antenatal checkup, she was found to have PIH. Natal emergency lower segment cesarean section was done. In the view of impending eclampsia, that means the blood pressure was so high she was about to go for seizures. At 29 weeks of gestation, baby did not cry immediately after the birth and required intubation and resuscitation in the delivery room. So postnatally, child was taken to NICU. As the baby's breathing had not established, we had put the child on ventilator for 4 days, and totally about 21 days the baby was in the hospital. On day 2nd, the first episode of seizures occurred. There was difficulty in initiating feeds because baby used to aspirate. They had actually a pseudobulbar palsy in this child. Developmental history, gross motor, child neck holding has not yet attained. Even at 2 years, the neck holding was not attained. And fine motor, hands were kept closed, not approaching items. See, there is thumb inside the palm. At 6 months, when the baby is shown an object, baby sort of tries to grasp it by reaching for it. It had not attained. Even at 2 years, language, only cooing is attained. Because 2 years, they should be able to say 2-worded sentences, which was not attained. Social, emotional, does not recognize the mother yet. You know, at 3.5 months, most of the babies do recognize mother and give a social smile. Family history was normal, nothing significant there. When we examined the child, there was opistotonic posture, there was cortical thumb. This is what we call as a cortical thumb, that is the thumb inside your hand. This is one of the soft neurological signs because it should open up. If it does not open up, there is some amount of neurological problem in this child. When we measured the head, there was microcephaly, there was spasticity because tightness was there. All the 4 limbs, there was spasticity. And deep tendon reflex were exaggerated in this child. And there was ankle clonus in this child. More than 20 ankle clonus was there. So the diagnosis was global developmental delay. That means everything aspects, all the 4 aspects of the development were grossly delayed in this child. So in this case, this was due to cerebral palsy because this child had a possibly intrauterine hypoxia. Child needed resuscitation, had seizures in the newborn period. This child might have had an intraventricular hemorrhage also because that child was 29 weeks. These premature babies have got a very high incidence of intraventricular hemorrhage, which is going in for cerebral diplegic type of cerebral palsy. So causes of global developmental delay and cerebral palsy form one of the major causes for it. Then there is early environmental deprivation. As I said in one of the earlier classes, that when a child is emotionally deprived, for example, a child in a foster homes, child in a hostel, which nobody is taking care of the child, because baby, as he develops, he requires that physical stimulus, mental stimulus, social stimulus, and emotional stimulus. If that is not given to the baby, foster homes, or a child who has got a single parent, or unwanted child, these are the ones are emotionally deprived. So these are the ones that's going to have a problem. And there are certain neuromuscular disorders. You have anterior horn cell disease or any other neuromuscular disease, because the babies are going to lie down in their beds all the time without the stimulus, can get into gross global developmental delay. They can have congenital brain malformation. For example, they have a congenital hydrocephalus. a congenital malformation of any of the cerebral structures. Then there are various syndromes, Down syndrome or major malformations which can give rise to global developmental delay. Genetic disorders can cause that. Plus, of course, the metabolic disorder, whether it's carbohydrate, fat, or the protein metabolism, inborn errors of metabolism can cause global developmental delay. So how do you manage these children? A formal developmental screening can pick up global developmental delay early, because it's very important. Every child, as they grow, we need to regularly do the developmental assessment in this child to pick up early. If you pick up early, you can start the therapy early and you can have near normal child as early as possible. Detailed history and examination can establish most of the etiologies, because with your history and examination itself, you can able to find out most of the causes. Example is they had cerebral palsy, 29 weeker. Intraventricular hemorrhage is common, which is causing that cerebral diplegia. The diagnosis. So based on this evidence, specific investigations are suggested. If it's an intraventricular hemorrhage and periventricular leukomalacia is there, MRI can be done and you have the diagnosis there. Early intense intervention helps in many children, because this is what is important as this global developmental delay. Early intense intervention is the most important to have as normal a child as for the parents. So let's go to another case. This is a 4-year-old Nishant, history given by the grandparents. He speaks less than 10 words. All his needs he points out with the fingers, shows interest in other children, but he is not able to sort of communicate with other children, makes good eye contact. History of excessive gadget exposure, because what happened was this child takes the phone from the grandparents and start playing video games, and also he uses the TV frequently, seeing all those cartoons all the time. Birth history is nothing significant. Developmental history, it has attained all milestones appropriate for his age except for the speech, and on examination clinically there is nothing significantly wrong with him. So everything is his developmental history, birth history, his examination, everything is. Only problem is the speech. Now in this we call it as what is called as a specific language disorder. This is that they have spoken and written language are composed of receptive and expressive language delay. There are two types. The specific language disorders, there are two types. One is receptive and expressive language delay. That is, receptive means listening and reading. That means when somebody tells you something, you listen and then you comprehend what has been told, and then you can speak or understand. Second is when you read from the book, you see the letters, you see the words, you see the sentences, and you'll be able to comprehend what it is. This is receptive. And understanding and processing the word. This is important. That is, you understand the words and process the words. Whereas other one, what we call as a expressive, it is about speaking and writing. So you want to tell something, say for example a word or sentences, you need to understand what that is and then you speak. And also similar way, you want to write about a boat. You understand what a boat is, what it does, say sails on the floats on the water. So you need to sort of write that thing, because you are understanding the figure of the boat and you are writing about the boat. So this is what we call as a expressive language. So you can have both receptive separately, you can have receptive language disorder, or you can have a expressive language delay. So let's try to find out what is the difference between a receptive language disorder or delay and an expressive language delay. 0 to month, usually what happens in receptive language, alerts to voice, because when the mother says something, see, immediately he turns towards the mother and tries to find out who it is. Whereas expressive is that he cries or he coots. 4 to 6 months, he responds to the voice or name. So this is the time when mother calls his name and he knows that, okay, those words are heard, it is processed and it is understood, and he feels that it is for him and he responds to that. That's a receptive language. And whereas he enjoys seeing the mother, so he knows that as he laughs and he babbles. 7 to 9 months, turns head towards the sound. Whereas the sound is coming, he turns towards that. Whereas expressive, he says mama, baba indiscriminately. 10 to 12 months, enjoys peekaboo. That is a game, like he goes behind the mother, then pulls him outside of that thing. It's called a peekaboo. Understands no, follows one step command with a gesture. Like you say bring, he say bring. Come, he'll say come. Like that single command gesture will be there. And says mama, dada appropriately, and waves bye-bye and shakes his head and no. If he wants to say no, he shakes, because he understands that's a language he can say, or a gesture he can say. 13 to 15 months, follows one step command without the gesture. That means you say bring that glass, he'll bring that glass. He understood what you have spoken to him, and the brain sort of tries to comprehend what it is and makes him to do it. Points to one body parts. He'll be able to say nose, show your nose. He'll be able to show your nose. Then in expressive, he has immature jargoning up to about 5 words. He indiscriminately speaks with a different type of words. 16 to 18 months, points to one picture. 3 body parts, maybe ear, nose, eyes, he'll be able to point when you asked him. Mature jargoning with true words, up to 25 words he'll be able to say. 19 to 24 months, he begins to understand pronouns, follows 2-step command. Like you say that you go to front room, bring that pen here. He'll be able to do that. There are 2 processes, that is going to the room, different room, and bringing the pen. So he'll be able to do that. Then up to 50 words he'll be able to speak in expressive language and 2-worded sentences like you bring, I bring, those kind of words, 2-worded sentences he'll be able to say. 25 to 30 months, point to the body parts of the picture. You show him a picture and tell him where is eyes, where is legs, where is hands. They'll be able to do it. And 50% of the speech is intelligible, because intelligible speech of about 50%. At 3 years, he knows the opposite. You know what is left, what is right, and white, black. Those kind of opposite words he'll be able to know that. Whereas in 3 years, he knows about 250 words and he'll be able to form 3-worded sentences like for example, I will go in car. So there are 3-worded sentences he can speak to. 4 years, follows 3-step commands and points to 4 colors. He will be able to comprehend there are 4 colors and he'll be able to point out red, green, white, black. Like that he'll be able to say 4 colors. Answers when questions, like when you ask him a question, where is your dad has gone? He'll say he's gone to the factory or he's gone to the clinic. Tell stories. He'll be able to tell you small stories. 5 years, he begins to understand left and right, because you show him which is left, he'll be able to say this is my left and this is my right. Answers why questions, because you ask him why is sky blue, or you ask him why there is light in the room, or when there is dark in the room. He'll be able to answer that thing and defines simple words. He'll be able to define what it is. So this comes at around 5 years of time. So in this child, how do you manage? Effective communication is very important. It is necessary for learning, social, emotional, developmental interaction. So here if you see that case, what happened? He was too much involved in the gadgets. Now where is the stimulation? You need those physical stimulation, sensory stimulation, then hearing stimulation. All this stimulation will make them to interact, comprehend and produce this language interactions. Formal audiology evaluation is a must, because all these language disorders, please take an audiology reference. Early recognition and intervention is at most important, and speech therapy. It's very important, because if you see, there is a difference between the speech and language, because speech is trouble producing certain sounds accurately. So you will not be able to produce that sounds accurately, like stuttering. You can have that. That is the speech thing. Whereas language disorder, it's like understanding, comprehending, and producing the language. So that is language disorder. So it's very, very important for us to have this. There are three basic speech impairment. That is, one is articulate disorder. Second is fluency disorders. Third is voice disorders. These are the three basic speech disorders which can have. Let's come to another case. This is a 4-year-old Krishank. History given by parents. Very naughty behavior noticed since started walking. He doesn't sit for a minute. If taken to some function, he runs, screams, disturbs others. And whatever task is there, he finishes fast and disturbs others. Because in the school, if he is given a task, he'll finish it and troubles the others after finishing the task. If taken to some function, he runs, screams, and disturbs others. This is, I think all the mothers dread this, because when you go to somebody else's or relatives or friend's house, and this guy will climb on the sofa, pull all the things there, and break some crystals or break some china, and mother has got no face to keep her this thing because of this guy's hyperactivity. School teachers complaining about he doesn't sit in one place. He doesn't sit in one place. So he'll sit for 1 minute, he goes and disturbs others. He keeps doing it. Too much talkative. So doesn't wait for his turn. So birth history, nothing significant. Developmental history, nothing significant. Father also had similar behavior during childhood. That means, mother says, grandmother was telling, the father also had the similar inattention, hyperactivity during his early childhood. No other significant finding in this child. So you all know this is a important, almost about 10 to 12% of all children goes through this, what is called as a attention deficit hyperactivity disorder. They have a poor attention span, ADHD, poor or short attention span or excessive activity, and impulsiveness, inappropriate for child's age, that interferes with the functioning or development. That means to say that it is for his age, that excessive activity and impulsiveness is there. ADHD affects about 18 to 11% of school-going age, twice as common in boys as in girls. Many features of ADHD are often noticed before the age of 4 years, invariably before the age of 12 years. Because when they go to the preschool, that's the time when teacher says that he doesn't sit in a place, he goes and troubles, he tears the thing, he spoils his toys. These are all the things what they say, attention deficit disorder in this thing. There are 3 forms of attention deficit disorders. One is inattentive, second is hyperactive, third is combined type of ADHD. Here in inattentive, they don't have the attention span. They cannot sit in one place at the thing. They'll go, jump and all those things. The second is hyperactive. Again, they'll be climbing up the things, pulling from the others. This is the hyperactive type of ADHD. Third is you have both types, inattentiveness and hyperactivity together it is there. So it is not uncommon to see isolated inattentiveness, isolated hyperactivity, or combined type of ADHD. So how do we diagnose it? This is what is called as a DCM-5, that is diagnosis statistics of mental disorders. So this is by the American Association of Psychiatrists. This is the 5th edition, which comes with these 2 different charts where we can diagnose ADHD by using this. First is often fails to give close attention to details or makes careless mistakes in homework, at work, or with other activities. Often has trouble holding attention on tasks or play activities. Often does not seems to listen when spoken directly. That is, when he is doing something, you call his name, he never sort of responds to that. Often does not follow through instruction and fails to finish the schoolwork, because he will try to do something for 1 or 2 minutes, then his attention goes somewhere else. He does not finish chores or duties in the workplace. Often has trouble organizing tasks and activities, because you tell him to do something, he will not able to start that work in them. He'll go there, go here, he'll tries to see what the other ones is doing. This is what he does. Often avoids, dislikes, or is reluctant to take tasks that require mental effort for the long period of time, because he does not like, say for example, sitting and doing maybe some continuous work. He tries to avoid most of the time. Often loses things necessary for the task and activity. You give them crayons, he loses the crayons, or you ask him, give him some instrument to do some work, he will lose that instrument. And often easily distracted. When he is doing something, suddenly there is a bike sound. Immediately what he does is, he immediately leaves his work and goes and finds out what it is. So this is what it happens. Often forgetful of a daily activity. A certain age, you're supposed to do certain things on a daily basis. Say for example, if you have to wear a board to the school, he is forgetful about it. If he has to carry the bag, he is forgetful about taking that bag to the school. And in this, 6 or more from each group in 2 or more situations, and must interfere with social and academic function. So another chart is about how this child are hyperactive or impulsiveness is there. Often fidgets or taps hands or feet or squirms in the seat. Often leaves seat in a situation when remaining seat is expected. See, when the class is going on, all the students have to sit in one place. But this guy is so hyperactive, he doesn't sit in his place. He's more interested in what the other guys is going, or what is outside in the classroom. So never sits in his place, often runs or climbs in the situation where it's not appropriate for him to do so, often unable to play or take part in a leisure activities quietly. That is, when he's say playing cricket or some other thing, he'll shout and disrupt the thing, he'll come and push the wickets, he'll take the ball and don't give it to the bowler. These kind of things he does that. Is often on the go, acting as if driven by the motor, because the parents always say, grandparents say that he does not sit in one place till he sleeps. He is on a continuous motion. He is there, and often talks excessively, often blurts out an answer before the question has been completed, often has trouble waiting for his or her turn, because if they're in a queue, he doesn't stay in the queue, he wants to come in front and do the thing. And when somebody is doing that, he does not allow that person to do it. Often interrupts or intrude on others. These are the things. Again, 6 or more from each group in 2 or more situations must interfere with the social or academic function. So what is the treatment? Drug treatment if the hyperactivity is too much. We give methylphenidate, which is a stimulant, and that and other group of drugs like atomoxate, clonidine, guanfacine. So these are the drugs which are used in treatment of attention deficit hyperactivity. Along with the drug, it is very important for us to sort of give behavioral therapy. It forms the cornerstone of treating attention deficit hyperactivity children. That is behavior therapy with behavior modification techniques. Younger children benefit from the combination therapy, because younger children will require drug as well as behavioral therapy. For the preschool age children, behavioral therapy alone is needed. So for this, only the behavioral therapy, when you find them in an older age group, that should try to make them better. So one more case, that is 3.5-year-old Sumit. History given by the mother, does not speak. Poor eye contact, not interested in other children. Most of the time he plays alone. Play school teachers complain that doesn't respond when it's called, because when he is sitting there repeatedly calling his name, he does not respond, as if what they're calling doesn't sort of interest him. He does not hear. He doesn't play with other children, because when they're in the group, he'll be alone doing something. doesn't sit in one place, because she does not sit in one place, pushes other children, and hence they've refused to allow him to play in the school room. So mother also tells he spins most of the time. He keeps spinning small things all the time, afraid of mixer. When when he hears a big noise, he starts screaming and he runs to the mother and tries to hold her tightly. Like, for example, the grinder sound, pressure cooker sound really irritates him and scares him. Gets irritated when his routine is changed. For example, when he's doing something and you try to bring him to do some other thing, he gets irritated, starts crying and having temper tantrum there. Birth history was nothing significant. Developmental history, motor milestones were attained appropriate for age. See, this is very important, because what parents, when they come to you, is in the initial phase, all the motor milestones will be normal. They will vouch their child was absolutely normal till 2 years and something happened. Could be the immunization, could be the medicine what you have given. They'll try to blame it on that. So, but what happens here is they will be mainly seeing about the motor milestones, which is achieved normally in this children. So, it's very important for you to take the complete developmental history very well. Here, speech and social milestones were lagging behind. On examination, clinically, he was perfect. All the systems were normal in this child. This is a child with these kind of symptoms. When you see no eye-to-eye contact, this is one of the important thing what you have to, because when you come across, you may not be pediatricians later in life, but if you see a child who does not have eye contact, who's sitting in the corner playing with himself, not with the other children when they are there, and when mother calls him, he is not at all responding, make this early diagnosis and tell the mother that your child needs a consultation with the developmental pediatric. You will be doing something really good for this child. Autism spectrum disorders are the condition in which people have difficulty in developing normal social relationship. When I see a friend, I have a social sort of a relationship with him, your brothers, your sisters, your schoolmates, but here it does not take place. Use language abnormality or not at all. Show restricted or repetitive behavior. This is what the autism spectrum disorder is. So, according to CDC, Center for Disease Control, there are about 1 in 54 children in US with a male-female ratio of 4:1 have autism spectrum disorders of some kind. Let's see what are the important clinical features of autism spectrum disorders. Here you can see there is displaced indifference. Mother will be speaking to him, he is not at all interested what's happening. Apparent insensitivity to pain, that means if he falls down, he does not cry. If something happens, touches him, he does not cry or shows insensitiveness to pain stimuli. May not want cuddling, that is, if the mother is trying to hold, he just refuses to be cuddled by the mother. Avoid eye-to-eye contact. I told you this, very important. Eye-to-eye contact is very important in human beings. Echoes words or phrases, because when you talk to him, when you ask him to tell something, he tells exactly what you're saying. Echoes, that is what it is. No real fear of danger, because he'll go to the terrace and tries to find out what is down. He's not scared of it. He crosses the roads without even looking at that. He plays with the electrical things without getting scared of that. And sustains unusual or repetitive play. Like, for example, if he is playing with a small toy of it, he keeps playing for hours together with the same toy. Even though there are so many other toys, there are other noises, he is not distracted with that. He keeps doing repetitive things. Inappropriate giggling or laughing. He'll be suddenly coming out with laughing episodes, giggling episodes will be there. And insistent on alikeness, because he goes and sees in front of the mirror, likes that image of himself in the mirror. He likes that likeliness in that. May prefer to be alone, because when there is a group of children, he goes alone in the corner and start playing foot with himself. Trouble in interacting with others. As I said, it's something like same thing which is occurring here. You can see these children are playing. This guy is on the side. inappropriate response or no response to the sound, say for example a mixer, grinder, or even the darkness. For example, if he asks to go up to the first floor where there is no light, he's scared, he does not want to go there. Sudden mixer grinder sounds, pressure cooker sound, he shouts and comes to the mother. Inappropriate attachment to the object, say for example he likes a small plastic red block, he keeps it as if it's precious, made up of platinum or a diamond, and he sort of guards it all the time, does not want to give it to anybody. Trouble in expressing the needs. He wants to drink water, he wants to drink milk, or he wants to eat something. He has got an inability to express what he wants to the mother. And spins object, as I said, all the time he turns the object as if spinning effect on that object is there all the time. These are the features of autistic spectrum disorders. So diagnosis, as per the DCM, I said, DCM 5th edition book, you can see they have made this criteria. That is, A is impairment in social communication and interaction. That is the communication and interaction. B is that restrictive and repetitive patterns. Restrictive, his number of things what he can do is restricted, and also what he does is repetitive. This is A and B. It's together you can make a diagnosis of this autistic children. So how do you manage these children? It's very important to screen for specific autistic spectrum disorders. It's usually done at 18 to 24 months and whenever the risk factor detected on surveillance. If the doctor is able to sort of get a suspicion on this, you need to do it early. Otherwise, 18 to 24, every child has to go through a screening test to pick up these children early. Applied behavior analysis like individualized intensive program focuses on achieving social communication and competence, emotional and behavioral regulation, functional adaptive skills necessary for independence. Educational programs, speech and language therapy is important because this is, if started early, they're going to reach a stage where they can be independent on their own and able to sort of interact with the society at large. Treatment, sometimes we may need to give drug treatment for them, and selective serotonin reuptake inhibitors, SSRIs, what we call as serotonin reuptake inhibitors like fluoxetine, paroxetine, fluvoxamine. So these are the ones which we use as a adjective to the behavioral therapy. Antipsychotic drug like risperidone is also being used in these children to some extent of success. So let's come to another case. A 10-year-old Ayan studying in the 5th standard with a history given by the mother complained he is not interested in studies. He is slow in writing, illegible handwriting, simple spelling mistakes all the time, mirror image writing notice, that is, he is confused with P with Q, B with D, like for example bus, he'll write dus. He sort of confuses these two opposite lined letters. Confusion in mathematical signs, whether it's plus or minus. So he'll be, when you're given addition, he'll minus it and give you the answer. So he has got a difficulty in finding out what is plus and what is minus. In the school, he's getting promoted since 1st standard. We all know, now I think till 5th or 7th standard, no child can be kept back in this same standard. So they are promoted despite. So their problems are not sort of diagnosed and given a proper attention for that. He has been going for tuition because mother felt he was not up to the mark. So she's been sending him, she's been sending him for tuition since the age of 1st standard. See what terrible, with 1st standard we are sending children for school. It's tuitions, it's really bad. He spends most of the time in front of the books but without any improvement. Poor chap. He's trying to please everybody. He's trying to sort of learn hard. So he sits most of the time in front of the books, but he's not able to comprehend and understand and not getting good marks. He's very good in sports and extracurricular activities. He is in at least 3 to 4 different school teams in extracurricular activities. Birth history, developmental history was normal. Family history, he has one elder sibling who's in 9th standard with a similar history, because this child also at that age had the similar problem. Both parents are well qualified and they are working. There is no other abnormalities noticed in this children. So this is what is we call as a learning disability, or a specific learning disability, or learning disability is there. So what is the definition of learning disability? When an individual's achievement on an individually administered standard test in reading, mathematics, or a written expression is substantially below that expected for that age, schooling, and level of intelligence, then we call it as a learning disability. Let me come again. That is, when an individual's achievement in individually administered test in reading, in mathematics, in written expression is substantially below the expected age of schooling and the level of intelligence. So learning disabilities have got 3 common types of learning disorders. Dyslexia, that is reading disorders, and dysgraphia, disorders of written expression in writing. And third is dyscalculia, that is, you all have seen a beautiful movie by Amir Khan, Tare Zameen Pe. There, that child, if you have seen it, if you have not seen it, please go and see it, because that child who had this dyslexia, how he tries to cope up with other children, it's just beautifully narrated in this movie. Learning disability, children at risk from learning disabilities are premature babies with postnatal complications. They are in the NICU, they've had a meningitis, they've had a sepsis, they had a birth asphyxia. These are the ones who have high incidence of learning disability. Cyanotic congenital heart disease patients who have had terrible postnatal phase, and a positive family history. It's very important. If you ask this parents or a grandparents how the parents of the children were, you will get a positive history in that. Red flag signs are child with a speech delay. You try to find out any problem, a child who coming with a speech delay, does he have learning disability or not? We need to sort of assess these children. Clinical features are trouble learning nursery rhymes, because how much ever time you small, like twinkle twinkle little star, Baba black sheep, they are not able to sort of able to reproduce the same thing. They find it so difficult. Failure to recognize letters and numbers. A, they won't be able to do it. Or numbers like what is 6, they are not able to say it. Failing grades, they tend to lose their marks. Problem connecting sounds and letters. So for example, big and God, they're not able to sort of connect. Bus and dust, they're not able to connect it. Poor comprehension, because when you speaking something, they're not able to make out what you're saying. Fear of reading aloud. He avoids reading aloud. You ask him to sort of narrate what he reads, he's not able to do that. Difficulty in counting. You ask him to say 1 to 20, he's not able to say that. And finger counting, he's not able to count his fingers. Difficulty in fractions, because very difficult. This is one of the very important. A little older child, you ask him to divide 10 by 5. He is not able to divide it. The fraction is very, very difficult for them to understand. Difficulty with mathematical concept and reasoning. Sign confusion, because you put a sign. For example, you put a arrow. He is not able to make out why it is for. Sign confusion is there. Illegible handwriting. His handwriting may not be able to read. Avoidance to write. He somehow tried to skip, because teacher will keep complaining he does not write it in the classroom. Frequent omission of letters and words. When he is writing a sentences or when he is writing words, he usually will miss some words. He'll miss some letters and he miss some words in the sentences. Most common comorbid condition, because this learning disability and ADHD, many of the children, it is sort of a comorbid. Anxiety and depression also is present. If you see, because what happens is, because of the behavior, the other child try to sort of detest them and may not mix with them. That's why it can give rise to anxiety. Little older children, it is very common to have children with a specific learning disability or learning disability can have this anxiety and depression. So how do we manage? Detailed history and neurological examination is important. Screen for vision and hearing problem. All these children need to go through a vision and hearing test. Psychological evaluation, educational management like remedial therapy, individualized education plan, IEP, because it's very important, because they cannot have the same comprehension like other children. So these are the ones which require individualized attention. So there is what is called as an individualized education program for them. I think we need to involve them in this. No drug treatment has got much effect on academic achievement, intelligence, or general learning ability in the child. So another girl of 10 years, 5th standard, history by the parents, complaints of poor in academics, getting promoted to school since early standard, does not know about the days, dates, color, time and money concept even when she is 10 years. No improvement even with repeated teaching, because mother has really worked with her. She's been teaching every day about the things surrounding her, even the classes, but she's not improving at all. She's comfortable with children younger to her, because you see, a child who's supposed to be in 10th standard tries to play with a child all the time with who's 4 years, 5 years, or one first standard child, then there must be something wrong with them. 10th standard child would like to play with the children of his age. He will play the games what a 10th standard child should be playing. But he is playing, or she is playing with the children of first standard or 4 or 5 years old child, peekaboo, then those hide and seek and all that. Then you know that there is something really wrong with this children. She has poor communication skills. When she is asked to tell something, she cannot sort of fluently tell that problems. She needs help of the mother in taking bath and some assistant. Even physical activities like which needs a finer skills, she is not able to do, so she gets bathed by the mother every day. Birth history, mother had epilepsy on anti-epileptic drug during the pregnancy, because mother was an epileptic patient. She was taking anti-epileptic drugs. Baby was born, full-time vaginal delivery. Natal and postnatal history was of no problem. Developmental history, all milestones were attained late, and family history, nothing significant. On examination, no positive finding whatsoever. In this child, it is intellectual disability is the diagnosis. This child is intellectually disabled. What is intellectual disability? Its a definition is intellectual disability includes cognitive IQ, that is less than 2 standard deviation below the mean, that is IQ is about less than 70, and adaptive function, that is less than 2 standard deviation below the mean. Adaptive function refers. Intellectual disability definition is it includes a cognitive IQ which is less than 2 standard deviation below the mean, that is IQ is less than 70, and adaptive function, that is less than 2 standard deviation below the mean. Adaptive function refers to how an individual functions in their environment. How an individual functions in their environment. If you are given a environment, say for example school, how does this child function in the school? Whether she is moving with the other children, she is adapting to the other children, is she adapting to that environment of the school? It includes the measures of socialization, because how she socializes with others. Communication, how she communicates with others of her needs or what they want. And what is her motor skills? Say for example, she is able to do something, writing, motor skills, whether she is able to do it. Activities of daily living such as dressing and toilet, if she is able to do it. So clinical features are delay in language development. You saw that this child has got language delay. Social development can be slow because of cognitive impairment and language deficiencies, because the social development, since they are not able to do it, they themselves will not go to the other children and socially interact with them. So this is because of cognitive impairment and language disorders, language deficiencies, it happens. Slow to learn to dress and feed themselves, because you see, sometimes the parents give the history. She is 10 years, but still the mother has to feed her. Behavioral problem, that is explosive outbursts. Sometimes they can have temper tantrum, physically aggressive or self-injurious behavior. Because what happens is that if they are not given something, if they have told something, they get angry, they bang their head, they cut their hand, and they do a lot of temper tantrum. This is a disruptive behavior is there. They have anxiety. They also have depression as they reach a older age. How do you manage them? So very important is clinical evaluation is very important. They have to sort of check what is the problem is. Standardized testing for IQ, because if you see, we have the IQ measurement by the clinical psychologist. She has to find out what is the IQ level, what is there, and assessment of adaptive function, how the child is going to adapt with their other people. Educational program, because these are the children who needs a special education, individualized education program prepared by the multidisciplinary team, sort of to bring them to the normalcy as ever. So this is a 5-year, 8-month-old female. History given by the parents. Complaint of non-fluency of speech noted since about 18 to 20 months. She was struggling to initiate speech, repetition of the same sounds before processing further, stretching the words with blocks during the speech. Problem is increasing as the days are progressing. Sometimes she is showing different facial expression of struggle during speaking. This is increasing when others are asking a question and in school interviews, because this baby is really struggling. She initiates, but she cannot complete. She goes on stretching the words, or she has got sort of a blocks in between. And especially it occurs when somebody asks sudden question to her. So these are all symptoms what they had. So birth history was normal. Developmental history, she attained all milestones except speech, which started speaking words around 2 years, 8 months. That was late. Now she is speaking everything. Father had similar problem in the childhood. Family history is there. On examination, she was clinically perfect child. This is the diagnosis. That is, this child has got stuttering. It's a terrible disease, really makes them feel low. So the diagnosis is stuttering. What is stuttering? It's a speech disorder. Repetition of the sounds, syllables or words, prolongation of the sounds and interruption in the speech is known as blocks. It is also known as stammering, stuttering and stammering. You all know, you've heard some of your friends have that. I think it's terrible for that child when in the school, when all are normal and this baby is stuttering or stammering. There are types of stuttering, 3 types to be precise. It is developmental stuttering, neurogenic stuttering and psychogenic stuttering. That is developmental stuttering, neurogenic stuttering and psychogenic stuttering. So what are the causes? Usually in most of the children, the father has got a history or a mother has got a history of stammering or stuttering in the early childhood. And developmental during the childhood, if it is delayed, you should suspect this. Or in the neurogenic stuttering, brain injury from stroke may lead to neurogenic stuttering. And severe emotional trauma can lead to psychogenic stuttering, because for some reason a child was absolutely normal, there is no family history, development is normal, but for some reason there is a severe psychogenic trauma which has occurred with the child, developed into that. So stuttering, how it occurs? Repeats a part of the words. Example, he say tat 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 table, or tat 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 table. This is one of them. Or he uses a sound like table, like that he will use that thing. Or prolongs or holds a word. So sun, like this he will use that. Or breaks or stops in between repetition of the words. He'll say sun, like this he'll use it. struggle to produce speech, or getting tensed while speaking. Suddenly what happens is he'll try to do expression changes and all like that. He tries really hard to bring it out, which he really wants, but he cannot do it. So how do we manage this child? Speech therapy by the speech and language pathologist reduces the interruption in the speech. Now there are many software also available which you can use, that it teaches them how to sort of come out of the blocks and improves the child's self-esteem. Therapy focus on controlling speech pattern by monitoring rate of speech, and they give breath support and laryngeal tension. They use the different laryngeal tension to sort of relieve these blocks in these children. So we have gone through this, different types of developmental disorders. So now let's go through the quizzes. I'm sure you're able to answer it. So, which is not the type of learning disability in this thing? Is it dyslexia? You know, dyslexia is a learning disability. Dysgraphia is a learning disability. Dyscalculia is a learning disability. Intellectual disability. So, intellectual disability is not a type of learning disability. It is learning disabilities, dyslexia, dysgraphia, and dyscalculia. What are the forms? Which are the forms of ADHD? Inattention, hyperactivity or impulsiveness, combined, all of above. All of above, because you can have some children with inattention, some children with hyperactivity or impulsiveness, many of them with combined. All of them sort of forms of ADHD. Stereotypic behavior is seen in autism spectrum disorder. Yes? No. You all know, you saw that spinning effect. They are playing with the single toy all the time. They have this stereotypic behavior all the time. So thank you. I am sure. So it is for the children so difficult to sort of interact, socialize with other children of the society. Imagine the mother who's looking after this child. The complaint from the school, complaint from the other children's parents, spoiling their toys, taking their pens or pencils. And they cannot go anywhere because of this hyperactivity behavior in the child. Now the present time, when we have every parent wants their child to come first in the school, your child is lagging behind. And you're comparing your child with other children every day, every minute, every second. It's a terrible thing for the parents. As a doctor, when you approach them, it is not the helplessness, because there are methods to improve them if detected early. So autism spectrum disorders, ADHD, learning disability, this all need to be picked up early and given behavioral therapy, medication. You can bring them to near normal as possible only if it is done early and picked it up. So students, today you went through a different case scenarios and you are able to make a diagnosis and able to pick it up and treat it. So thank you very much. I am sure you will never miss autism spectrum disorder ever. Thank you so much. Thank you.